Occupational English test. Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I've been having a rough time managing all my health issues lately. With my blood pressure, diabetes, and now these seizures, it's just too much. Plus, this persistent dry cough and hoarseness have been bothering me for months now.
I understand it must be overwhelming. Let's take it one step at a time. Can you tell me more about your recent head trauma and how it's been affecting you?
Well, a few months back, I slipped and hit my head on the cement. Since then, I've had this constant neck pain and dizziness. It's hard to concentrate, and sometimes I feel like it's affecting my balance too.
That sounds quite challenging. Have you noticed any changes in your symptoms since the incident, especially with your dizziness or neck pain?
The dizziness comes and goes, but the neck pain is constant. And it doesn't help that I have this ongoing anxiety. I'm seeing another doctor for that next week.
It's good to hear you're getting support for your anxiety. Now about the cough. Have there been any triggers or patterns you've noticed?
No specific triggers, but it's been getting worse. I used to work with asbestos, which I'm worried about, but I've never smoked. The cough is dry and it's tough to breathe when it hits. My voice has been gravelly for a while now.
We're doing the right thing by scheduling a chest x-ray. It's important to rule out any serious complications. Have you had any issues with your medications?
Honestly, it's confusing keeping track of everything. My phenytoin levels were off last time, and I think they might increase my dose. They're also stopping my lisinopril because of the cough.
Managing multiple medications can be challenging. Let's make sure to address this in our plan. Now, how about your diabetes control? Any concerns there?
It's been hard to keep stable. My last hemoglobin A1C was 7.2%, which isn't too bad, but I know it could be better. I'm on metformin, and there was talk about possibly adjusting my diabetes medications too.
Keeping your A1C at a stable level is crucial, especially with your other conditions. We'll look into optimizing your diabetes treatment during your follow-up visits. Have you had any recent episodes or changes in your pain or seizure frequency?
My seizures have been a bit more frequent, which is worrying. The pain from my carpal tunnel syndrome and the chronic pain elsewhere, it just adds up. Sometimes I feel it's too much to handle.
I'm sorry to hear that. We'll review your pain management strategy thoroughly. It's also important we keep a close eye on your liver function, given your history of hepatitis and the medications you're on.
I appreciate that, doctor. I just want to feel like I'm not just jumping from one crisis to another.
Absolutely, our goal is to get you to a more stable and comfortable place. Let's review today's findings and our plan moving forward.
Please.
Firstly, your vital signs today are relatively stable, with a blood pressure of 142/88, which we'll continue to monitor closely. Your liver and renal function tests are within normal limits, which is good news. The phenytoin level, however, is subtherapeutic at 12 mg/ml, so we'll need to adjust that. The imaging results, including the chest X-ray and liver ultrasound, didn't show any acute issues, which is reassuring.
That's a relief to hear.
Yes, it's a positive sign. Moving forward, we will stop the lisinopril to see if it improves your cough. We'll adjust the phenytoin dosage to achieve therapeutic levels. For your diabetes, we'll consider adding or adjusting medications to better manage your blood sugar levels. We're also scheduling a pneumonia vaccine today to protect your respiratory health.
And the referrals?
We're referring you to a liver specialist to ensure comprehensive care given your hepatitis history, and we'll arrange for a thorough examination of your throat to address the hoarseness and cough. We'll also continue to monitor your liver function and diabetes with routine tests.
Thank you, doctor. It sounds like a solid plan.
You're welcome. We'll meet again in 4 weeks to review your test results and update the treatment plan as needed. Please remember to keep track of your symptoms and medication intake. It's key to managing your health effectively.
I will, doctor. Thanks for helping me sort through all of this.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, doctor. I'm here for my follow-up. I think we need to look into a few things that have been bothering me lately.
Good morning. I see this is a follow-up visit. Could you start by telling me more about the issues you've been facing recently?
Sure. I've been having more trouble with wheezing and shortness of breath, especially when I'm trying to sleep or after some physical activity. It's been quite bothersome.
I see. You mentioned it happens more at night and after using the treadmill. Have you noticed any specific triggers or patterns?
Well, it seems to get worse after I eat certain foods. Pasta with tomato sauce, for instance, seems to make it much worse. I'm wondering if it's related to my reflux symptoms. I've been experiencing more of that lately too, especially at night.
That's helpful to know. We'll consider how your gastroesophageal reflux might be influencing your respiratory symptoms. How about your diabetes and cholesterol management? How have those been going?
I've been pretty consistent with my medications, metformin and glipizide for diabetes, and simvastatin for my cholesterol. I monitor my blood sugar regularly, and it's been within a decent range, though my last HbA1c was a bit above the target. And my last cholesterol check wasn't great either. My LDL was higher than we'd like it to be.
It's good that you're keeping a close eye on these conditions. Let's make sure we recheck your cholesterol levels soon. Now, regarding your medications, are you finding them manageable? Any issues with side effects or costs?
The medications are okay, but the costs can be challenging. I asked last time about getting handwritten prescriptions to reduce the co-payment through the VA.
We'll make sure to address that and find the most cost-effective options for you. Besides these issues, how have you been feeling overall? Any changes in your diet or exercise routines?
I've been sticking to my exercise routine at the gym, mostly treadmill and some weights. I avoid white foods, sticking mainly to whole grains. I think it helps.
Maintaining regular exercise and a healthy diet is excellent. Now, you also mentioned some concern about erectile function and a prostate check.
Yes, that's correct. I've been a bit concerned about my sexual health, and I thought it might be good to discuss potential options and maybe get a check for any prostate issues.
Absolutely, we can arrange for a PSA test and discuss your concerns regarding erectile function. Ensuring your overall health includes addressing these aspects too.
Thank you, doctor. I appreciate you looking into all these areas. It's a lot to manage, but I'm trying to keep everything under control.
You're doing a great job managing these complex health issues. Let's go over everything we've discussed to ensure we have a clear plan moving forward. Your recent cholesterol levels show a total cholesterol of 200 mg, LDL at 130 mg, HDL at 42 mg per liter, and triglycerides at 175 mg per liter. For your diabetes, your fasting glucose was 108 mg, and postprandial was 160 mg per, with an HbA1c of 7.2%. Your pulmonary function tests show a mild obstructive defect with an FEV1 of 80% predicted and an FEV1-FVC ratio of 75%. Your blood pressure was 138/88 mm, and your prostate-specific antigen was 1.8 nanogram/ml.
That's quite detailed, doctor. What's the next step then?
For your cholesterol, we'll have you fast and return for a recheck to decide if we need to adjust your simvastatin. We'll continue monitoring your blood glucose closely, and given your symptoms of reflux worsening at night, I think starting a medication to suppress stomach acid might help alleviate your wheezing. Regarding the prostate and erectile function, once we confirm your cholesterol and diabetes are stable, we can consider medication for erectile dysfunction. We'll also plan for a PSA test tomorrow.
Sounds like a comprehensive plan. I'll make sure to follow through with everything.
Perfect. I'll see you back here in 1 month to review all the test results and adjust your treatment plan as needed.
Thank you for your thoroughness, doctor. I'll see you next month then.
You're welcome. Take care, and don't hesitate to reach out if you have any questions or concerns before our next appointment.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
All right, team, let's focus on refining our emergency protocols today. Our primary goal is to decrease response times and improve patient outcomes.
I've noticed that the coordination between triage and treatment could be faster. Perhaps we could assign a dedicated person to bridge communication gaps?
That's a good point, Lisa. We could implement a role for rapid response communication, especially during peak hours.
Also, we should consider frequent drills to ensure everyone is familiar with their roles in various emergency scenarios.
Agreed. Let's schedule monthly emergency drills. I want everyone to rotate through different roles to build versatility and confidence.
Should we also update our equipment checklist? Some items are outdated, and having the latest technology could enhance our efficiency.
Absolutely. Submit a list of what needs to be updated. Remember, our objective is clear: swift, coordinated care that saves lives.
Now look at question 26.
How are you feeling today? I'm here to check on you and the baby and see how your recovery is progressing.
I'm feeling a bit overwhelmed. The baby is healthy, thankfully, but I'm exhausted and a bit sore.
That's completely normal. It's important to rest whenever you can. Have you been able to sleep when the baby sleeps?
I try, but it's hard. I worry about doing everything right.
It's okay to feel that way. You're doing a great job. Let's go over some tips for managing your rest and the baby's care.
Thank you. That would be really helpful.
Also, remember that it's important to take care of yourself too. If you need to, we can discuss options for support like a postpartum nurse or joining a support group.
Now look at question 27.
Thank you all for coming. Today, we need to evaluate the effectiveness of the new anticoagulant we've been prescribing.
I've compiled data from the last 3 months. There's a significant reduction in thrombotic events among our patients, but we've seen some issues with bleeding complications.
Is the incidence higher than with the old medication?
Yes, slightly. It's effective in preventing clots, but the risk of bleeding might offset the benefits for some high-risk patients.
We might need to consider patient selection criteria more carefully, perhaps adjust dosages.
I agree. Tailoring doses based on individual risk factors could mitigate some risks. I'll start drafting some guidelines based on our findings.
Excellent. Let's proceed with that and monitor the outcomes closely. We need to balance efficacy with safety.
Now look at question 28.
How have you been feeling since our last appointment? Any changes in your symptoms?
There's been a bit more shaking, and I feel stiffer in the mornings now.
It sounds like your symptoms might be progressing. We might need to adjust your medication. Are you experiencing any side effects from the current treatment?
No side effects, but it just doesn't seem to be as effective anymore.
Okay, I think it's time to consider either increasing the dose or adding another medication to help manage these symptoms. I'll also recommend some physical therapy to help with the stiffness.
Thank you, doctor. I just want to maintain as much independence as I can.
Absolutely, and we'll do everything we can to support that goal. Let's review these changes in detail and make sure you're comfortable with the next steps.
Now look at question 29.
We're planning your discharge for tomorrow. Let's go over everything to ensure you're ready to continue recovering at home.
I'm a bit anxious about managing at home. What should I do if there's an issue?
First, here's a list of signs to watch for that would require you to call us or visit the ER. We're also setting you up with a home health nurse for the first week.
That's reassuring. What about my medications?
You'll continue with the same medications you've been on here. I've organized them into a pill organizer and included a schedule for you.
Thank you, that helps a lot. What about follow-up appointments?
I've scheduled a follow-up with your doctor next week. It's important to keep that appointment so we can assess how well you're doing.
Okay, I've got all that. Thanks for making this feel manageable.
Now look at question 30.
I understand you have mild chronic kidney disease. I'm here to go over your medications and make sure they're safe for your kidneys.
Yes, my doctor mentioned something about not taking certain pain relievers.
That's correct. Medications like ibuprofen can further damage your kidneys. You should use acetaminophen for pain instead. Let's review your current prescriptions to ensure they're all safe.
Okay, what about over-the-counter medications or supplements?
It's important to avoid certain supplements that can harm your kidneys. I'll give you a list of what to avoid. Also, always check with us before starting anything new.
Thank you. I didn't realize how many things could affect my kidneys.
It's a lot to manage, but we're here to help you. Keeping your kidneys healthy can be done with the right precautions and regular monitoring.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Today, we delve into the complexities of Barrett's esophagus, a condition marked by the transformation of the esophageal lining into a type more resistant to acid. This adaptation, while beneficial against acid reflux, brings about its own set of challenges, including a predisposition to esophageal adenocarcinoma. Recent updates in the 2022 guidelines from the American College of Gastroenterology emphasize nuanced changes in screening and management strategies. To better understand these updates, let's discuss a pertinent case study that highlights the intricacies involved. We begin with a patient, Mr. Thompson, a 58-year-old male with a long-standing history of gastroesophageal reflux disease GERD. He presents with classic symptoms of heartburn and regurgitation, which have persisted despite the use of over-the-counter antacids. Notably, Mr. Thompson is also a smoker and reports a family history of esophageal cancer. Given these risk factors, age, male gender, smoking, family history, and persistent GERD symptoms, Mr. Thompson fits the profile for a candidate who should undergo screening for Barrett's esophagus. Screening for Barrett's esophagus has traditionally been performed using upper endoscopy. However, the new guidelines introduce additional modalities, such as unsedated transnasal endoscopy and a novel, non-endoscopic swallowable capsule. The latter, especially appealing for primary care settings, involves swallowing a capsule tethered to a string that expands into a sponge within the stomach. Upon retrieval, it collects esophageal cells for analysis, potentially identifying Barrett's esophagus without the need for a traditional endoscopy. In Mr. Thompson's case, an initial screening with the swallowable capsule was performed, which demonstrated abnormal cells indicative of Barrett's esophagus. Subsequently, a confirmatory upper endoscopy was conducted, which not only confirmed the diagnosis, but also revealed low-grade dysplasia. This finding significantly alters the management approach, shifting from surveillance to active intervention. Management of Barrett's esophagus, particularly with dysplasia, has evolved significantly over the past decade. Endoscopic therapies such as radiofrequency ablation, RFA, and endoscopic mucosal resection, EMR, have emerged as frontline treatments. These procedures aim to eradicate dysplastic tissue and allow for the regeneration of normal esophageal lining under intensive acid suppression therapy. Mr. Thompson underwent RFA, and follow-up endoscopy 6 months later showed no signs of residual dysplasia, indicating a successful intervention. This case illustrates the critical role of early detection and the effectiveness of contemporary management strategies in altering the disease trajectory of Barrett's esophagus. It also underscores the importance of individualized risk assessment in the screening process. According to the guidelines, patients like Mr. Thompson, who have multiple risk factors, benefit the most from early screening and intervention. The guidelines stress that not all patients with GERD require screening, but rather those with chronic symptoms and additional risk factors. Furthermore, the guidelines highlight the necessity of maintaining at least once daily proton pump inhibitor (PPI) therapy in patients diagnosed with Barrett's esophagus to reduce the risk of progression to high-grade dysplasia or adenocarcinoma. In Mr. Thompson's case, ongoing PPI therapy is recommended to manage his GERD symptoms and reduce the acidic exposure to the esophagus, which could potentially trigger dysplastic changes. Lastly, the integration of newer screening technologies, such as the swallowable capsule, into clinical practice represents a significant advancement in the field. These technologies offer a less invasive, more accessible approach to screening, which could lead to wider adoption and earlier detection of Barrett's esophagus across a broader patient population. The evolving landscape of Barrett's esophagus management, highlighted by the 2022 guidelines, offers promising tools and strategies for gastroenterologists and primary care providers. These advancements not only enhance our ability to detect and treat this precancerous condition at an earlier stage, but also emphasize the critical role of tailored patient care based on individual risk profiles.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Welcome to today's healthcare discussion, where we delve into the intricate and evolving world of pediatric osteomyelitis. Our focus today centers on the comprehensive management and diagnostic approaches required for effective treatment of this condition, drawing upon the latest guidelines and integrating a relevant case study to illustrate these points in a practical setting. Pediatric osteomyelitis, an acute or chronic infection of the bone, predominantly affects children and presents unique challenges compared to its adult counterparts. The pathophysiology in children primarily involves hematogenous spread of bacteria, typically following bacteremia. This contrasts with adults, where infections are often due to contiguous spread from soft tissues or due to direct inoculation. Let's start by discussing a recent case from my clinical practice. We treated a 7-year-old boy who presented with nonspecific symptoms of leg pain and fever. Initially suspected to be just a sprain or viral syndrome, the persistence of symptoms led us to consider more serious conditions. The turning point came when his blood tests showed an elevated C-reactive protein, CRP, which, as per recent studies, is elevated in over 90% of children at the onset of osteomyelitis. Upon suspecting osteomyelitis, the first diagnostic step was obtaining blood cultures, crucial for identifying the causative organism. As noted in the updated guidelines, blood cultures are positive in about 1/3 of pediatric osteomyelitis cases, providing a pathway to targeted antibiotic therapy. In our case, the cultures identified Staphylococcus aureus, aligning with literature that highlights it as the most prevalent pathogen. The role of imaging in osteomyelitis cannot be overstated. Initially, we conducted an X-ray, which did not reveal any obvious bone changes. Common in early presentations, as radiographic changes typically take 2 to 3 weeks to appear. Consequently, we proceeded with an MRI, which is highly sensitive and specific for early detection of osteomyelitis. The MRI confirmed osteomyelitis in the distal femur with signs of a small subperiosteal abscess, underscoring the need for an aggressive therapeutic approach. Management commenced with intravenous antibiotics, guided by the organism's profile and local antibiotic resistance patterns. It's essential to highlight that while the initial choice of antibiotics is broad, adjustments should be made based on culture results to avoid overtreatment and resistance development. In children, as the guidelines suggest, the shift from IV to oral antibiotics should occur as soon as clinically feasible, which is supported by studies showing no significant difference in treatment failure rates between prolonged IV and early transitioned oral therapy. Our patient was transitioned to oral antibiotics on day 3 after confirming clinical and laboratory improvement. Follow-up over the next 3 weeks showed continued recovery, with normalization of CRP and resolution of symptoms. This case exemplifies the critical importance of early diagnosis and appropriate management, including the timely switch from IV to oral antibiotics, which can significantly reduce hospital stay and cost without compromising treatment efficacy. Moreover, the case highlights potential complications that clinicians must vigilantly monitor. These include chronic osteomyelitis, growth disturbances, or pathological fractures, particularly in severe or inadequately treated cases. Regular follow-ups are imperative to monitor for these complications, especially in children where growth and development can be impacted. Managing pediatric osteomyelitis requires a nuanced approach that emphasizes early diagnosis through clinical vigilance and the strategic use of diagnostic tools. Adherence to updated clinical guidelines ensures effective management while optimizing antibiotic use to prevent resistance. Each case must be tailored to the individual, considering the specific clinical scenario and the patient's overall health context. This approach not only improves outcomes for the individual child, but also enhances overall pediatric health management strategies.